Good afternoon, everyone. My name is Hannah Podhorzer, and I will be your moderator for today's Renfrew Center Foundation professional webinar, Why Telehealth, the Renfrew Center's groundbreaking virtual treatment outcomes. Following the training, you'll receive a handout featuring key slides from the presentation by email. Before we begin this webinar, I'd love to provide a bit of background on Renfrew for those who may not be as familiar. The Renfrew Center, family owned and operated, has been the pioneer in the treatment of eating disorders since 1985. As the nation's first residential eating disorder facility, Renfrew has helped 100,000 individuals move towards recovery by providing them with the tools they need to succeed in recovery and in life. In 1990, the Renfrew Center founded the nonprofit Renfrew Center Foundation, whose mission is to advance eating disorders education, prevention, research, advocacy, and treatment. To date, the foundation has trained over 50,000 therapists, dietitians, medical providers, and other mental health professionals. It is now my privilege to introduce today's speaker, my colleague, Dr. Melanie Smith. Melanie Smith, Doctorate of Philosophy, licensed mental health counselor, certified eating disorder specialist, and approved consultant, is the Director of Training for the Renfrew Center. In this role, she is responsible for developing and implementing clinical training and programming that is consistent with emerging research and evidence-based practice. Dr. Smith is co-author of the peer-reviewed treatment manual and patient workbook, The Renfrew Unified Treatment Model for Eating Disorders and Comorbidity, published by Oxford University Press. Dr. Smith is also a certified therapist and trainer of the Unified Protocol for the Transdiagnostic Treatment of Emotional Disorders, UP. We are grateful and excited to have Dr. Smith with us today. So without further ado, I'm going to pass it on over to you, Mel.
Thank you, Hannah. And thank you to everyone out there that is joining us today for this webinar. We really do appreciate your time, taking time away from your patients and your practice to learn something new and hopefully interesting to you. This presentation today is going to be covering some researchy things, but my intention is to cover it in a way that is digestible and makes sense and is not too bland or boring, because it actually is a really important, relevant, salient topic. And we would love to share with you the research that we've conducted. So we are going to be speaking about a specific published article that we will give you all the citations and information for at the end. But first, I just wanted to give you some background for why we even conducted this study in the first place. One, it was just necessary and important, because if we're going to be developing and delivering programming to people who really need help, we need to care a lot about whether or not that treatment is actually helping them. So we've had an established research department for many years that has conducted a lot of treatment outcome research and published a lot of treatment outcome research. But when it comes to virtual treatment and research around virtual treatment, there was a lot of work that needed to be done in order to do that. So, and that's what's going to be described in this study today. We know that teletherapy for eating disorders is not a brand new idea. There are studies that have been conducted in years past, but a lot of those studies really called for additional research and also just noted that more accessible evidence-based treatment for eating disorders is needed just broadly, globally. Because there are so many barriers to accessing care. In the previous studies that happened, there was demonstration of efficacy for virtual treatment or teletherapy treatment of eating disorders, which is wonderful, specifically with bulimia and binge eating disorder. However, there was actually very little research examining anorexia or other types of eating disorders, such as ARFID, or old school EDNOS, excuse me, but currently not otherwise specified. So there were limitations in what the research was as of several years back. And what some of the findings were, though, in those studies were that the trajectories of recovery or improvement in treatment in outcome were slower in virtual than in face-to-face. That's kind of what the existing literature had said. But as I mentioned, we really hadn't studied anorexia very much in virtual delivery prior to 2020. And what also hadn't been studied was the delivery of group eating disorder treatment, which is the typical type of treatment that happens in higher levels of care, such as an intensive outpatient and partial hospital. So that's actually explicitly what we're going to be looking at today. And there's a reason for that. There's a reason that PHP hadn't been studied too much, especially in a virtual realm. One, it really, prior to 2020, wasn't really being done very much. There were very few places that were even experimenting with this at the time. And there are just unique challenges when conducting experimental controlled research that's in a higher level of care environment, especially when we've got high acuity of symptom severity, and we know that treatment is very intensive and expensive, which can make conducting clinical trials very difficult and a little ethically gray area. We also know that it can be hard to study higher level of care, whether it's in a virtual or an in-person environment, because there are so many different presentations, symptom presentations, diagnoses, clinical presentations, and the actual treatment itself has lots of different modalities, different types of groups that happen each day, multidisciplinary teams. So while some of the naturalistic studies of PHP prior to this did show a demonstrated benefit of a treatment effect from admission to discharge in areas that were really important, the actual parsing out of the variables and determining what elements of the program were more effective and being able to really isolate that made it pretty difficult to conduct research in this way previously. And that's still true, but it could be one of the reasons why there wasn't as much literature in this area in the first place. We at Renfrew knew that we wanted to develop a virtual IOP and PHP many years ago, more than 10 years ago. I was on a work group or performance improvement team. We came up with lots of ideas and proposals, and we kind of kept hitting brick walls. We really wanted to do this, but we were also just very overwhelmed with the logistics and the pragmatics of it. We really just couldn't conceive of it, or we could conceive of it, but we also could conceive of all the different ways in which it would be difficult and challenging. But everyone knows what happened in March 2020. I don't need to tell you. But we were kind of pushed in the direction of figuring it out. We had to be brave and curious and a little bit adventurous in order to do this. But yeah, necessity was the mother of invention and innovation in this area when COVID came knocking on all of our doorsteps in March of 2020. So what we know that happened during that time was during, lockdown and all of the various many months that happened after that, the field saw a significant increase in the incidence and severity of all emotional disorders, not just eating disorders, but mood disorders, anxiety disorders. But when looking specifically at eating disorders, we found increases in depression and just general psychopathology in individuals with bulimia. It was found that folks with anorexia reported an increase in fear of food insecurity and restrictive behaviors. And we could, again, think about all the things that were happening at the time that might influence that, which, does anyone else remember standing in line early in the morning before Target to get your rations of toilet paper and other necessities? So it would make sense that when there's already fear around having enough food, and the actual world starts to change in a way where you're not sure if you can get the things that you need, that did not help with anything. And we also saw increased urges to binge and binge eat in individuals with bulimia and binge eating disorder. So we saw eating disorder severity and incidence increasing. So we saw a number of emergency department admissions related to eating disorders increase dramatically during that period. And we, like everyone else, had to very, very quickly figure out how to transition to telehealth because it was not an option to provide in-person services for any outpatient level of care, whether it was directly outpatient, intensive outpatient, or partial hospital. And that a lot of folks, a lot of clinicians transitioned exclusively to teletherapy once the stay-at-home orders happened. But there were no guidelines for anyone to figure out actually how to do this, which left a lot of us with a lot of questions to be answered. And again, we kind of had to just figure it out pretty quickly. We at Renfrew were, though, at a very significant advantage despite this really difficult kind of global adversity, because we had already, as a program, as an organization, underwent a very large-scale evidence-based implementation project beginning back in 2013. so well before COVID, with full implementation of a evidence-based treatment across all of our locations, all 19 locations, by the end of 2015. And we were supported in that effort by research practice collaboration partners at Boston University, University of Albany, and Drexel University. So we received a ton of knowledge and experience in implementing evidence-based treatments and learning just how to implement clinical innovation using evidence-based implementation practices from our university partners. And that knowledge and information was critical in us being able to successfully transition. And there were also elements of what we implemented that gave us a significant advantage as well. So what we had implemented back beginning the process in 2013 and completing the process in 2015 was the Unified Protocol. So if you're not familiar with the Unified Protocol, the full name is the Unified Protocol for the Transdiagnostic Treatment of Emotional Disorders, also known as the UP. That was developed by David Barlow and his colleagues at Boston University. And what it is in a nutshell is a unifying treatment that takes the most potent mechanisms of mindfulness, of CBT, of motivational interviewing, of acceptance and commitment therapy, of dialectical behavior therapy, and exposure and response prevention through the process of really complicated factor analysis. What was the most potent mechanisms that are shared amongst each of these existing empirically supported treatments, and how are those brought together in a unifying, stepwise, thoughtful way? That's what the Unified Protocol is. And that had a lot of demonstrated benefits in a variety of settings. So that's what kind of piqued our interest to implement this at the Renfrew Center, again, beginning that process in 2013. The evidence-based transdiagnostic mechanisms of change, and I do want to share these now because this is the treatment that we studied in the virtual environment, were these 5 mechanisms, which were the reevaluation of unhelpful maladaptive cognitions, changing action tendencies, which basically means behaviors, because you can't achieve recovery without changes in behaviors. Doing that via reducing emotion avoidance, because we identify emotional and experiential avoidance as key maintaining factors of eating disorders, as well as other related comorbid conditions. You do that through utilizing emotion exposure procedures, building emotional tolerance, which is combating emotion avoidance, right? To build tolerance to difficult emotions and experiences, which is a key construct in treatment for eating disorders, and doing all of that through increasing cognitive and psychological flexibility in emotion regulation, meaning the more that we can assist folks in regulating their not so helpful emotional reactions and responses, the less they will need eating disorder behaviors to cope. That's the treatment. That's the big picture. The Unified Protocol was really seen as a good fit for our environment and our population because it's highly emotion focused, and we believe that eating disorders are disorders of emotion. Another significant benefit to me as the director of training, meaning I was, part of the team that needed to train all of our clinicians in this, is that it's not overly complex. It's very principle based. And if I can teach people key transdiagnostic principles, those can be applied in a variety of settings across a variety of patient populations, which really provides a unifying way to conceptualize patient problems and to develop treatment plans. So it was really beneficial in that way, and also very scalable. It can scale up and down for different levels of care. And since we offer a variety of levels of care, that was really desirable. And it's also adaptable to a staged approach because not everyone starts and ends treatment in the same place. We need to be able to meet people where they're at. So we can adjust and start people where they are at in order to move them forward in their treatment and recovery. So there were many significant advantages to that we identified back in 2013 that also proved to be advantages when trying to implement this in a virtual environment in 2020. But the Unified Protocol was not explicitly an eating disorder treatment. It was an emotional disorder treatment, which, again, we conceptualize eating disorders as falling under that category of emotional disorders. But we also recognize, especially when we started really piloting it with our patients, is they really wanted and needed and could benefit from explicit interventions that are more tailored to specifically address eating disorder symptomatology of restriction, binge eating, purging, compulsive exercise, things like that. So we tailored it and adapted it in order to do that a bit more explicitly for our patients to make it more tangible for them. We also integrated, and we thought this was really important, relational cultural theory principles. Renfrew as an organization, when it was first founded in 1985, was founded in this basis of relational cultural theory, and that is still true today. So that was really important in kind of maintaining the integrity of the program, but also really integrating it with these evidence-based principles for the unified protocol. So we developed our own adaptation, which is referred to as the Unified Treatment for Eating Disorders and Comorbidity. Here's a nice little illustration of how that treatment kind of plays out in that staged approach, as I mentioned earlier. And again, all of this comes from that original unified protocol, which is that distillation of CBT, MI, ACT, DBT, and exposure. So starting treatment with an emphasis on motivation, goals, and values, because I don't know how else you would start treatment. We have to be able to acknowledge and assess and address ambivalence and all the reasons that folks may want to change, and also all the reasons where they may be terrified to do so, and how incredibly normal that is, and be able to attach all those reasons to really important value-driven goals so that folks can do the really hard and courageous work of change, which we realize, again, can be very, very difficult to do. Our first foundational skills are really around mindful emotional awareness and acceptance, building an awareness of just the fact that we have emotions and that they are important, even the ones that are bad, quote unquote, anxiety, fear, disgust, guilt. Recognizing that we actually, all of our emotions have an adaptive function. We don't always experience them adaptively, but we actually need all of them. We shouldn't be trying to suppress them or avoid them or push them away. We build on that emotional education by getting more complex and in-depth understanding of emotions, of the three components of an emotion, our cognitive component, our physical sensation component, and our urges and behaviors, and how those all connect together. And learning the fact that, again, all emotions actually can and do have an adaptive function. Whether or not we express them that way is another question. And all emotional experiences unfold in a certain timeline. In antecedents, meaning these are things that activate our emotions. We have our emotional response, which is multifaceted, but there's also consequences, ARC, both in the short term and the long term. And this is where folks really start learning and understanding the connection between their emotional experiences and their eating disorder behaviors. And this is a pathway to change. So the pathway includes increasing flexibility in cognitions, which individuals with eating disorders are not necessarily known for, right? Known for more rigidity in cognitions. Therefore, the flexibility is really, really critically important to change. Countering emotion-driven behaviors or symptoms, right? Learning and identifying other skills and ways to utilize the emotional information we're getting and utilize them in a more adaptive and helpful way. And a lot of that has to be done while also tolerating really difficult and uncomfortable physical sensations. Uncomfortable physical sensations are part of all emotional experiences, but they're an extremely visceral and critical part of eating disorder experiences. So we do need to explicitly target that in treatment, because that's something that absolutely can bring folks back to square one if we're not addressing it. And that the pièce de résistance, kind of the big kind of finale at the end, is bringing all of this together and utilizing emotional exposure strategies in order to build that emotional tolerance and resilience, which is a significant pathway to recovery. So when thinking about and now getting ready to look at what the study looked at, it's important to recognize what treatment mechanisms we were looking at and how we conceptualize the treatment and how it leads to improved outcomes. So when we have our model, the key treatment mechanisms that we're looking at in this study today, as well as our other published studies, are increasing mindfulness, because we recognize, again, that mindful awareness and the ability to not run or escape from our emotions, to be present with our emotions, even when they're really difficult, is a key factor in preventing the use of disordered eating behaviors, reducing emotional avoidance, and decreasing depression and anxiety, because we know that co-occurring depression and anxiety can be a factor in contributing to relapse or regression in treatment. So when we're able to target all of those mechanisms, which are specific targets of the unified treatment model, we hypothesize that folks won't need to rely on their eating disorder symptoms as much to cope, which hopefully will result in better long-term eating disorder outcomes, not just short-term, because a lot of times when we're studying things, we're looking from admission to discharge. We need to be able to look further than that, look 6 months out, 1 year out. Is the change sustainable? That's a big important question. And that, again, we also saw and reduced anxiety and depressive symptoms. So the current study that we're talking about today, as it relates to telehealth, is we wanted to be able to explain the key adaptations that were necessary in order to implement the unified treatment model in a virtual partial hospital setting. And we wanted to be able to do a basic comparison, a preliminary comparison of patient outcomes or treatment improvements, right, for those who attended virtual PHP, which is labeled as VPHP, compared to traditional in-person PHP, which is labeled as TPHP. And we will use those designations moving forward. So we utilize the same implementation science framework that we used back in 2013 to implement the unified protocol originally to implement our adaptation to virtual treatment in 2020. So this is called the CFR, the Consolidation Framework for Implementation Research, which helps really frame how it is that we're actually supposed to do this in a way that is sustainable. So pre-implementation, we had to do a lot of work very quickly around preparing for the transition for both our patients and our staff, creating new program schedules, digitizing all of our patient materials that normally would be done with a workbook in-person treatment, but had to be created for a digital environment. Needed to pilot test the technology, which was probably one of the hardest parts for all of us, and really scaling that up and creating and delivering trainings to our internal staff to get them ready to do this. But all of that had to happen in 1 week's time. So my team and I didn't sleep for about a week, but we pulled it off because we had to. Again, necessity being the mother of invention and innovation. Some of the adaptations that we had to make that were just procedural, but I think are important to point out, is that we had to make changes in the way that we monitored important vital signs, specifically blood pressure. So we had folks purchase digital blood pressure cuffs. You can do that off of Amazon relatively inexpensively. And we've also utilized various ways to capture weight. Important to note, there's a double asterisk here. We were only collecting weight for individuals that needed that. If they were on, they had a weight restoration goal or a nutritional rehabilitation goal that was being measured. That is not necessary to be measured from a lot of people that are in eating disorder treatment. So I just wanted to put that out there. So this was if and only if it was relevant to the treatment outcome for that specific patient. Otherwise, we actually weren't collecting it. And we also needed to make significant adaptations in the way we monitored and supported meal completion because we're not physically across the table from folks. We were across the screen, across the state. So we had to do a lot of adaptations to figure out how to make that work. So all of our 17 outpatient locations, we have 19 locations, 2 are residential, the other 17 were IOP PHP, needed to transition within that 1 week, which again was an unforgettable week in my life. But the unified treatment was seen as a good fit for the virtual programs because it was manualized. We already had a manual with different modules in it. It was modular and scalable. It was transdiagnostic. So again, when we see patients that have lots of comorbid conditions, that would translate here. It improves accessibility and reduce the burden. There's a lot of generalizability to real life, and there were already built-in opportunities for community and connection in the way the program was structured before we had to move it to PHP. So we know that all of the work we did in those years from 2013 on with developing and implementing the unified treatment model, with standardizing our programs, with providing layers of structure for clinical supervision of our staff in providing the unified treatment model, and all of our data collection procedures, because we've been conducting research for many, many years, all of that was very critical to enable us to quickly and relatively smoothly transition into virtual treatment. So it was hard, but it was doable because all of the work that had been done before. So now that we're going to start to look at the study and look at our comparison groups, I do want to define a few things. So when we're looking at our TPHP or traditional in-person PHP program, that's a 5-day per week program. That was 6 hours per day. It says up to 6 hours per day, but we had already standardized that. It was 6 hours a day for all programs, which consisted of group therapy of different, there might be nutrition-related group therapy, skills-based group therapy, all in the unified treatment model realm, as well as other relevant groups, family groups, other basic psychoeducation groups. There were included 2 coached supported meals virtually, or not virtually, this is in person, excuse me. Family therapy, individual therapy, nutrition, individual nutrition therapy and planning, and psychiatric consultation. Okay, so that's what we're talking about in our traditional PHP. I thought I had a slide that explained virtual PHP, but I guess what I will say is I probably forgot it, but all of those things were still the same in virtual PHP, except for the delivery on the virtual format. So it mirrored as close as possible. The VPHP mirrored the TPHP structure as close as possible. So when we conducted this study, it's important to know how we did that. So in traditional PHP, our research assessments were given at the time of intake, as well as the time of discharge, and administered on-site using an iPad. And all of those assessments were completed within 1 week of admission and 1 week of discharge. All of those things were still true for virtual PHP, but instead of people sitting on a sofa in a group room on an iPad, they were using a universal link through Qualtrics to be able to take their surveys on their computers at home. And we did that as part of a group. But again, the timing and the frequency of assessment was the same in both groups. The traditional, the sample that we used for our traditional PHP comparison group were the patients that were treated immediately prior to COVID happening. So we looked at a sample as close as we could, because we tried to get our samples close together in time, because we wanted to do as best as we could to compare apples and apples and not apples and oranges. And we knew that as the environment and world was changing rapidly in COVID times, we were trying to get our comparisons groups right back to each other. So we had a total of 140 patients in the sample for this published study, 70 in each treatment group. So 70 in traditional PHP, 70 in virtual PHP. We have since collected significantly more data than this, but for the purposes of the study and for publication, we kept it to this sample so that we could get it published as soon as possible. Because anyone who's ever attempted to do that before knows what a feat that is. Obviously, all people in both groups consented to use of their data for research and completed all of the assessments. This is just an illustration of our patient demographics for those that participated in each sample. And really, there were no statistically significant differences between these two groups. They were pretty similar groups, with the exception of step-down status from residential being, which was a variable that we did look at, because we recognize that individuals who had a residential treatment episode immediately prior to either in-person or virtual PHP likely are going to have differences in the amount of change that they can have in the PHP program if they've already made significant change in residential. So we did need to look at that variable. But so that was the only real difference between the groups, was the percentage of folks that had already had residential, but we did control for that. We needed to measure a lot of different things. So these were lengthy measures. We measured eating disorder symptom severity using the EDEQ, depressive symptoms using the SESD, anxiety sensitivity and severity using the ASI and the OASIS, experiential avoidance, which I mentioned earlier is a key maintaining factor for eating disorders and one of our key treatment targets of the Unified Treatment Model using the BEAC, mindfulness being measured using the SMQ, and relational connection measuring with the PMED, which is a progress monitoring tool for eating disorders, which is a tool that we use weekly, actually, in our programs and have been using for quite some time to measure a variety of things. And then we also did include some opportunities for qualitative feedback around just general client satisfaction, using a basic Likert scale of 1 to 4 around their satisfaction with the treatment experience overall and certain elements of the treatment. We also looked at changes in level of care. I mentioned that earlier. Discharge status, whether it was a routine discharge versus a non-routine discharge, eating disorder diagnosis, so separating folks by diagnosis, anorexia, bulimia, binge eating disorder, and other. Also looked at comorbid diagnoses, trauma, anxiety, mood disorders, substance use disorders. And we did need to include BMI as a variable for individuals with anorexia only. Please know, the only reason that we included BMI because we recognize BMI to be a very unhelpful measure in pretty much all the different ways. is that it's virtually impossible to be able to publish any treatment outcomes articles related to eating disorders without the inclusion of weight data, weight change data. We wrestled with this quite a bit because we recognize that weight change is not at all the most important metric when looking at eating disorder treatment outcomes broadly. But in order to meet the standards for publication, that was required to be included. But we only used it for individuals with anorexia that needed to weight restore. So I just wanted to explain that caveat. So, and I'm going to try to keep this less researchy and dry. So I'm only going to kind of touch on this. So the statistical analyses, we utilize multiple regression to examine the treatment effect, comparison group, traditional in-person PHP versus virtual partial. And we controlled for baseline score, age group, comorbidity or number of comorbid conditions, and as mentioned before, residential step-down status. And our findings was that we didn't have that many findings, which was actually a really good finding, and I'll explain. So a lot of times as a researcher, it can be sometimes frustrating or disappointing when you conduct research and you don't have a lot of findings or statistically significant differences, because there's less to kind of say about that. But in this case, based on what it was that we were trying to measure, this actually was very good news. Because what we found was that virtual participants performed just as well as the traditional in-person participants in most salient target areas. So participants showed no statistically significant difference between groups in eating disorder symptoms and severity, anxiety severity, anxiety sensitivity, experiential avoidance, depressive symptoms, and relational connection with treatment team. And when I think about all of the things that are important to look at when we're trying to make some meaning of how well folks did in treatment or how well treatment did for folks, these are the things that we care about, and we found that there really was not a significant difference between groups, which was, again, a no finding, but a great finding all at the same time. So this will just kind of illustrate for you in a pretty simplified way what we're talking about when we say that there are no statistically significant differences. So we found very similar trajectories of improvement. So if you look at this top left, eating disorder symptoms, which again measured by the eating EQ, we look at where folks started at the beginning of treatment, which was higher, right? Higher levels of symptom severity. And we see a very similar slope or trajectory downward into less severity from admission to discharge. We found the exact same kind of slope and trajectory with with depressive symptoms. And again, similar, not exactly the same slope, but very similar trajectories with experiential avoidance. What I'll note is the slope on experiential avoidance was actually more significant in the virtual group as compared to the in-person group. We have some hypotheses about that. We have some ideas about that. And one of that is if treatment is being conducted in your real life environment, which it isn't usually, right? Because in-person treatment, you're going into a program, which is this like nice idyllic setting where everything is kind of controlled and taken care of. And so it can kind of like minimize those real life stressors for those hours that you're in program. If you're conducting treatment in your real messy life, because all of us live in our real messy life, maybe there's some benefits to that we hadn't thought about before, because treatment is actually being experienced in the place where the eating disorder is being experienced, which is in real life at your home. So one area that did show difference, which really was not surprising, was weight change trajectory. So we did find that individuals in the virtual group showed less improvement in weight change. And again, this was only measured and only a metric that was important for individuals with anorexia that needed weight restoration. So there was a slower weight gain in the virtual group than in the in-person group. I don't think this did or should surprise anyone. This is not surprising. And this is still a factor that we think about now that we are out of the emergency time with COVID, and we do have other options for treatment. For our Renfrew at Home programs, which is the name of our current virtual program that kind of grew out of this necessity from COVID, is that this is considered, significantly when we're determining appropriateness for in-person versus virtual treatment. So in-person still remains the prevailing treatment of choice for individuals that need more comprehensive medical monitoring and weight restoration. And that just, again, makes sense. So we do also know that, again, that our numbers on this can't be perfect because the weights needed to be taken via self-report. Some folks had numberless scales, not all folks did, because those were kind of a new innovation at the time in 2020. So we did have to rely on self-report. We did utilize family members, physicians, other folks to assist in trying to give us accurate numbers there, but we also know that we can't guarantee that. And we also know that realistically there was less supervision in meal prep, eating, and activity levels, which again could also account for that difference. But another finding that we thought was interesting, and again didn't anticipate, was that virtual patients actually showed more improvement in frequency of binge eating episodes, meaning they had a decreased number of binge eating episodes compared to in-person treatment. And again, we don't know for sure why. We can't say with scientific certainty, but our conclusion, similar to what we talked about with experiential avoidance, is that there is a benefit for folks receiving treatment in their actual home environment and learning to cope and use skills, adaptive coping skills in that space versus in kind of a bubble wrapped environment of being in treatment outside of the home. So that's a yes that we have. More study is needed, obviously, to kind of dig further into that. Another non-finding that was a really good finding was that we found no differences in relational connection. And this was a big concern of ours when we shifted into virtual by necessity, and was one of the barriers of us not doing this prior to COVID. Was so much fear around, we know that the therapeutic relationship is so important between the therapist and the patient, or any of the multidisciplinary treatment team members and the patient. We also know the relational connectedness with the other patients in the program is really important to healing and recovery. So this was a big concern, and what we were very pleasantly surprised to find was that there really were no statistically significant differences between groups with relational connection. People felt understood by their peers in their groups. They felt a sense of belonging with the patient community. They felt good about the relationships that they were developing in the program, and they felt accepted by their peers and by their treatment team for who they were. So all of that, again, continued to be pretty good news. We also, again, in our kind of, this was not a research measure, but just a more qualitative accounting of just basic satisfaction with the experience in the program. The scores ranged between good and excellent, and about 95% of the folks that participated in that sample at that time said they would recommend Renfrew virtual treatment to others, citing that it was more convenient and accessible for their life, which we believe to be true to this day. Other things that we found that we weren't necessarily expecting to find were an increased length of stay. We expected quite the opposite. We thought people were going to get fatigued and bored with virtual treatment, and therefore they were going to leave treatment earlier and quicker, and that actually was not the case. It actually increased length of stay. We also thought that it was going to increase absenteeism or premature discharge, and in fact it decreased absenteeism, because when all you have to do is roll out of your bed and into your computer chair, there are less reasons that get in the way, like transportation, schedules, things like that, in order to get to treatment. So it actually improved attendance and length of stay. And in a really big picture way, really important, was increasing access to care outside of like driving distance, outside of typical geography, which really expanded options for evidence-based treatment across the board, which was really good. So with any, if you're going to conduct studies and you're going to publish them and you're going to present that information like I'm doing now, we do have a responsibility, though, of course, to discuss the limitations and say that this isn't the end all be all and all of the information, of course, but we do have lots of reasons to be hopeful and excited about this. So we did observe that the unified treatment model, because of all of those elements I mentioned before, manualized, scalable, evidence-based, transdiagnostic, was a particularly good fit to transition to a virtual platform. We found that successful implementation is not only feasible and effective, but it's actually well received by patients, which was, again, it can be effective, but if people don't like it and people want to discharge prematurely and not get all of the treatment, it's not going to be as helpful to them. So all of those things were important. We also know that it's our initial results certainly support this being as effective as traditional treatment for many patients, again, with the exceptions of folks that need more medical stabilization and monitoring and weight restoration. We found that virtual treatment did not impact relational connection scores, and that was a really wonderful surprise and exciting. And we are continuing to find that as we continue to examine these outcomes. But that, again, step-down status was very much related to outcome in some way. So that needs to be continued to be a variable in further follow-up studies. Some of the limitations, this was not a true experiment. This was a naturalistic study. It had to be. There, unfortunately, were not, but we had follow-up assessments after discharge. But anyone, again, who's attempted to do this before, when you don't have a captive audience, meaning they discharge and go out into their life, getting folks to fill out research surveys is very, very difficult. And while we did conduct that, we did provide folks with these surveys, and some folks did complete them, we did not have enough of a percentage of completion to be able to include that data in the published study. So we are monitoring it, we are assessing it, but the follow-up rates are lower, and that's true across the board in any sort of long-term outcome research. And that continues to be a challenge that we have. Yeah. So how does this compare to other research on virtual treatment? Because we did make a bold claim in the title that this was groundbreaking virtual research. That was to get you to come to this webinar today. Well, but it kind of was. At the time of this being published, this was only the second published study to examine virtual eating disorder specific partial hospitalization outcomes. So pretty cutting edge, I'd say. So this research very well may support the use of virtual intensive eating disorder treatments longer term, which was a goal for us, certainly. And at the time of publication, only 4 studies existed that explored the outcomes for virtual intensive eating disorder treatment. All of those conducted within the last 3 years. This study was published in 2023. So all of those 4 other ones were between 2020 and 2023. So still very much in the infancy in this literature base. So some of the takeaways that are important would be that intensive virtual treatment for eating disorders is possible, and it provides similar effectiveness to in-person treatment. So while there had been very little data published in this area previously, as I mentioned before, we are really excited and proud to be able to contribute to the literature in this way, not only for our own treatment programs, but just acknowledging that this is something that is possible on a much larger scale and really should be considered across the board, really because it increases the accessibility in such significant and important ways. And that while some individuals may not prefer a virtual treatment environment, and that will always be the case, and that is okay, patients who attend virtual treatment share similar feelings of connectedness with staff and with peers compared to in-person treatment, which again was probably one of the biggest surprises and one of our biggest kind of hangups and barriers prior to doing this, was because we just couldn't conceive of how that would be possible. But this data is demonstrating that it actually is. And if you speak to the patients directly, or if you speak to the clinicians directly, what they will tell you, and again, for those of you clinicians who've been working since before 2020 and have continued to work now and had your own transition into this environment, I think most of us have been pretty pleasantly surprised to find how well you can establish and maintain a growth fostering relational connection with your patients, even if you're never sitting in the same room together. So this is very, very encouraging for individuals that just may not have options in their local, driving distance area, or may not have transportation. Obviously, significant implications for individuals who are caregivers, whether you're caring for children or other folks in your home, and not being able to leave for large chunks of time. It really, really opens up so many doors, as well as for folks that feel isolated in other ways. It's ways to provide connection even when those other barriers remain. The patients in the virtual group really did report similar reductions in those key treatment target areas, which is what we always have to be paying attention to. So they reported similar reductions in eating disorder behaviors, in rates of depression and anxiety, And the patients were more willing and capable of facing experiences that made them uncomfortable, which, if we are saying, and we are, that experiential and emotional avoidance and intolerance is a key maintaining factor, meaning it keeps eating disorders going. Therefore, targeting this and making improvement with this is a key factor in sustaining recovery and improvement in the long term, which is why this is so important and why we were so excited about these findings. So the big picture kind of takeaway message here is that virtual delivery of evidence-based, higher level of care is not only possible, but it actually increases the accessibility of high quality specialty care for individuals with eating disorders. So virtual is here to stay. It doesn't mean that it has pushed aside in-person treatment and programs. We still have those because we need those. So there are many folks that prefer it. There are many folks that need that. And again, for all of those factors we talked about before with, medical stabilization, weight restoration, psychiatric stabilization, if there's other co-occurring conditions that increase risk, or vulnerability, those folks would be better candidates. So all of those factors have to be considered in an ongoing way when we're assessing folks prior to admission to any level of care or any program. But the options have expanded considerably compared to where they were before. And I will always see that as a really, really positive thing, because it means less people are going to fall through the cracks. Less people are going to be suffering without options for treatment. And this really opens up the door in lots of different ways for those options. And we have really good data to support that it actually can help them. Not just that it's available, but it actually can be as helpful as traditional in-person programs. So the good news is both are available to everyone now. So here's just a little screen grab of the article that I've been referring to, or the study that we've been referring to. It's been published in the European Eating Disorders Review. So the citation is for you here, but if you are like me and like to read the article, which I do, I'm an article reader. I have so many PDFs that I've saved. Some I read, some I don't. But if you're a PDF collector like me, we'd love to help you hoard more PDFs. So very easy way to get that is to email us. You can, it's hard to see on the screen, but it's research underscore, so that underscore is kind of hidden, research underscore department at renfrewcenter.com. And you can just send a little quick email. Please send me the article, the virtual article, and we will get that right back to you. We'd love to share that with you. And there will be more, but this is the one that we have here. So with that, we're going to shift into some Q&A.
Fabulous. Thank you, Melanie, so much. You have such an ability to distill data into something that is so understanding. And I appreciate you sharing all of the work that you all put into this article and to Renfrew at Home. So before we begin the question and answer session, I did just want to provide a few updates on Renfrew's upcoming programs. So our next professional webinar will be held on Wednesday, May 22nd. It is titled In Sickness and in Health, Romantic Relationships in the Context of Eating Disorders Treatment. Following that presentation, our June webinar is titled Outside Their Window, Eating Disorders as a Regulating Strategy for Traumatized Nervous Systems. For additional information or to register for any webinars from this upcoming series, please visit renfrewcenter.com/events. And as Melanie just shared, I put the link in the chat to research_department at renfrewcenter.com if you'd like to get a free PDF of the article. So without further ado, we'll start getting into some of our questions. So one of the questions that we got is just kind of around the parameters of the study. I know you mentioned that you had controlled for age. Would you mind sharing what ages? Did you have both adolescents and adults? What did that look like?
That is a good question. Yes. So all of our programs, typically, there are some exceptions, are ages 14 and up. We do from time to time have individuals in IOP and PHP that can be slightly younger, 13 or 12, but in this sample, 14 and up. So when we controlled for age, we just broke into two groups, adolescent versus adult. So ages 14 to 17. And then 18 and up in comparison groups, but that we did not find any statistically significant differences based on age groups. So it didn't appear as if adolescents or adults had any better or worse treatment effect compared to the other groups. which is good and important because in virtual treatment in particular, we don't separate adolescents and adults. They're in group treatment together. So we are hoping that they're experiencing the same outcome or positive outcome, and the data is illustrating that they are. Yeah.
Wonderful. Thanks, Melanie. Our next couple of questions, I think, kind of pertain to just some of the vocabulary that we use in higher levels of care. I know that you spoke to routine discharges versus non-routine discharges. Could you give examples of like what a non-routine
Sure.
discharge
Yes. Routine discharges is what we want, right? That's ideal. That means someone has completed treatment primarily, meaning they've gone through each of the stages, because I mentioned it's a staged approach, but I didn't get into too many of the details of the stages. We have an engaging stage, which is pretty heavy on psychoeducation. We have a acquiring stage, which is skill acquisition, where there's a lot more experiential work. We're beginning exposure. And transformation stage, which is the much more intensive exposure element to the program. So routine discharge means someone has completed kind of the full course of treatment and are discharging, having met, most of their goals. A non-routine discharge, which of course happens in any treatment environment, would be when folks discharge early for any variety of reasons. One, because they say, this treatment ain't for me, this is too much, it's overwhelming, which is understandable. So they may discharge very early before treatment goals are met. They may discharge due to insurance-related reasons, right? It may be determined by their insurer that they didn't meet medical necessity criteria or have met, some other metric that does not provide for further coverage. So they need to prematurely discharge. If someone discharges against medical advice, that would be in there. So any of those scenarios or situations, or they need to discharge or choose to discharge because they want to go back to school, or any of those other things that kind of disrupt the full course of treatment, that would be a non-routine discharge.
Great, thank you. Another question around some of the different terminology we use is I wonder if you can share sort of the week in a life of IOP and PHP, like how many hours per week, how many times are folks seeing their different providers?
Yeah. So in both groups, in our traditional group and our virtual group, because again, we tried to create our virtual program to mirror as closely as possible the in-person program that's 5 days a week, Monday through Friday, 6 hours a day. So it's breakfast. Well, there's breakfast, there's morning mindfulness, there's UT skills group, depending on what stage someone is in, the engaging stage, acquiring stage, or transforming stage. Lunch and breakfast and lunch, again, those are on camera, coach supported meals with staff. Usually there's 2 staff in there, a therapist and a dietitian, depending, that are not only monitoring and observing the meal, and of course we have parameters around how that meal would work, where the camera is located so that the plate can be seen, and again using emotion coaching strategies to assist folks if they're struggling with the meal, which of course we can anticipate that some folks will. That's part of eating disorder treatment. And then after that, there are other skills-based groups or other theme, topic groups related to family therapy, nutritional education and information, and other skills-based groups. Then anyone that's in PHP is also meeting with their individual team. So they have a primary therapist that they're meeting with weekly. They have a dietitian that they're meeting with weekly to monitor their nutritional restoration and their meal plan and any changes or adjustments that need to be happen, as well as psychiatric consultation and medication management. So which they're meeting as needed. They're meeting for assessment and for monitoring of medication or changes that need to happen throughout. So it's a pretty intensive program. I mean, it's like a full-time, almost full-time job, right? 6 hours a day, 5 hours a week. And a lot of times those individual appointments actually will happen outside of those 6 hours. So you actually have a few of those days that might be a little bit longer than that. So it is intensive treatment, which again, if I, rewind to 10 years ago, I don't think I could have ever conceived that that would have ever been possible virtually. And it is. And again, we really thought that folks were going to have a harder time tolerating being on the screen. But again, we were really continue to be thoughtful and always trying to innovate and evolve so that folks can feel connected, can feel like you're in the room together, even though you're in your bedroom at home or wherever, in order to accommodate for that. And that, again, our length of stay is not going down, it's going up, or the amount of absenteeism is actually going down, and the treatment outcomes are holding. So what we once thought was impossible is actually quite possible. Yeah.
Love it. And I think that's a perfect segue. We got a couple of questions about the lovely topic of insurance in covering virtual treatment. So one provider had asked sort of on the topic of weight, how that has sort of looked in terms of insurance coverage, in terms of reporting of weight and things like that. And another provider had asked a really interesting question, since virtual care ideally has less overhead and are insurance companies, are they reimbursing in the same way that they are
Well,
in-person
okay. So
treatment?
first question, go back to what was the first question?
Yes, I gave you a lot. Our first question is around the topic of weight.
Oh, right. Yes. Well, as I mentioned before, we've long felt that like measuring weight regularly is not clinically relevant for all people with eating disorders. In fact, it's not clinically relevant for a lot of people with eating disorders, because we do not really believe that eating disorders are actually about food and weight. We believe it's about emotion and emotion regulation. So we are not prioritizing or mandating weight being collected for individuals that is not an explicit treatment target. So, and again, because if it's not clinically relevant, we're not particularly interested in doing it and subjecting people to that, or studying it. So we do have to study it though. And we do have to provide that to insurance companies in certain ways. So when there is a mandate for coverage, regardless of diagnosis, to be collected at a certain frequency, we do have to collect that in order for folks to maintain their coverage, in order to be able to stay in treatment. So we will collect it at the minimum, basically whatever the minimum requirement is. And there are folks that have more requirements because we are needing to more closely monitor weight fluctuations. So we do what is required, but only what is required. If it is not required or clinically relevant, we aren't collecting it, because we don't see the benefit in that. When it comes to the second question, I'm happy to say I have no idea the answer. I'm in the training department and the research department happily, and don't really have any connection to what happens in insurance contracts and things like that. So I really don't know the answer. I can't speak to that. I'm assuming it's complicated. But happily, I work in research and training, so I don't have to deal with the stress that is stressful. So I don't know.
That's okay. It's a great question, and it seems like a great place to be where you are.
Yeah.
And I'll probably finish us off, which will probably be the last question for the hour, is how did you all sort of handle the body image piece of people sort of seeing themselves on camera all day long and
Yeah,
continue
that
to do so?
certainly, came up. I mean, it comes up for me right now that I like work staring at myself all day. Like, who did that before, right? So, we do think and know that it's actually extremely important for folks to remain on camera in virtual care. And now that more telehealth standards and best practices have come out, like that remains to be extremely important for folks to maintain their presence on camera. One, just so that we can ensure that they are safe, that they are where they're supposed to be, that they're in a private location. So we do require folks to be on camera. But of course, have our therapeutic strategies for assisting folks in managing whatever discomfort they may have with doing that. But we are not able to permit folks to not be on camera, again, really for the purposes of just maintaining safety of folks. So it is an issue that comes up from time to time. What I'll tell you is it doesn't come up nearly as much now as it used to. I think all of us have gotten pretty habituated by and large to doing that. But there are also ways for individuals. I mean, thankfully, whether you're using Zoom or Teams or any other HIPAA compliant platform, which we use, of course, the HIPAA compliant platform, there are settings that folks can have that can hide their own view. So even if they can see the facilitator and see the group, they don't have to actually look at themselves the whole time. So it's a pretty easy setting to change. So that's actually probably the easiest solution. But again, body image disturbance is a relevant clinical issue. We would make it one of our, treatment targets to assess and address body image dissatisfaction that might be preventing folks from further engaging and participating. So we would address it the way we would in person, but yeah, otherwise there's neat little settings that make it a little bit easier.
Thank you. That will be our last question since we are just right at the top of the hour. And so if we didn't get to your question, I encourage you all to contact webinar@renfrewcenter.com. A reminder that a handout featuring key slides from today's presentation will be sent out to all attendees by email. As we conclude today's training, we want to remind you that the Renfrew Center is here as a resource for both you and your clients. Should you have questions regarding referrals, admissions, or support opportunities, please contact us at 1-800-RENFREW or by visiting renfrewcenter.com. Thank you again, Melanie, for this fantastic presentation. Thank you all for participating in the Renfrew Center Foundation's online webinar as well. Thank you all for your continued commitment as a resource to the community in this time. We look forward to seeing you at our next training. Take care, everyone. Bye.